Okay. Good evening, everyone. Can you hear me well? Yes?
Yes.
Okay, good. So I'm Dr. Dharmesh Mehta. I'm the president of APNO. I'd like to welcome you all to our webinar tonight. It was almost a year ago on March 11th, WHO declared COVID-19 a pandemic. So tonight we are going to learn about the COVID updates from our experts. Just for your knowledge, we are also running this webinar live on our Facebook, Neomed, Suma, Case Western. So we have a lot of people watching this webinar. First of all, it's my pleasure to introduce Dr. Shanu.
I left the video off.
Can you hear me? So first of all, now it is my pleasure to introduce Dr. Shanu Agrawal. Dr. Agrawal is infectious disease specialist at Suma Health. She is also one of our executive members. So please welcome Dr. Agrawal.
Thank you. Okay, do you want me to go ahead and share my screen?
Yeah, please.
Okay. Okay, can everybody see that? Okay. All right. Well, thank you so much for inviting me today to speak. And I have the pleasure of being here today and speaking with Dr. Thomas File, who is chair of infectious disease at Suma Health, and one of my colleagues, and also one of my other colleagues, Dr. Michael Chandler, who is chair of critical care at Suma Health. So I'm very happy that I could present with both of them. And the three of us have brief slides, primarily so we can answer some questions at the end. But what I'm going to do is really give an update on COVID-19 therapies from a year ago now and kind of what we're doing at Suma Health System. And then Dr. File is going to follow that up with the vaccines and the around the variants and talk about the variants. And then Dr. Chandler will discuss the ICU management of COVID-19 patients and hit on the complications such as the thrombotic events and also the post-COVID syndrome that we see in patients. So with that, I'll go ahead and get started. So COVID-19, 1 year later. So the first case of SARS-CoV-2 was actually diagnosed in the US January 20th, 2020, so about over a year ago. And at that time, there were likely more cases, but we were really limited on the testing that we had. Many places, many institutions were struggling with capability of testing. So we probably had more cases, but we just didn't know. The first case from January was published in the New England Journal of Medicine on March 5th. And at that time, between actually January and March, and probably even to the middle or end of March, we were still learning about how is the virus transmitted? What's the clinical illness? So we were learning that a lot of institutions were focusing on PPE. Do we have the supply or do we not? And since that time, we've really come a long way. I mean, we've learned a lot more about transmission, the clinical illness. We have more information, especially when it comes to clinical illness, about the viral response and the host response in COVID-19 infection. And that's sort of where my part of the talk is I want to discuss the therapies that sort of hit at the viral response and the host response. So this graph is a graph that sort of shows the different stages in COVID-19. So you have a stage 1, which is early infection, where you see a lot of viremia, high viral load. Stage 2 is your pulmonary phase, and these are when patients are coming in, and that's where you see the ground glass infiltrates on X-ray and CT scans. Stage 3 is a hyperinflammation. When you look at stage 1, this is where you have high viral response. And this is in the first couple of days. If you look, this is day 0, and this is beyond 10 days. And as you go along, you can see you have a greater host response as you go further into the disease. And that's where you get a lot of the hyperinflammation. We see elevated inflammatory markers. So that brings me to my first treatment option that we have that hits at the viral response. So SARS-CoV-2 monoclonal antibodies. until recently, the data really was not all that robust on monoclonal antibodies. And so a lot of the societies, Infectious Disease Society of America, really was unable to, say for or against the use of monoclonal antibodies in COVID-19 disease. The data that we've had so far is with small number of patients, which has shown a decrease in hospitalizations and death and reduction in SARS-CoV-2 viral load after 7 days. Most recently, the data has been strongest for a combination monoclonal antibody, which is the bamlanivimab and the atezolizumab. And that combination, monoclonal antibody combination, the preliminary data is actually quite promising and shows significant reduction in hospitalizations and deaths. So as of now, we have a few monoclonal antibodies that are available under emergency use authorization. And what I want to point out is monoclonal antibodies should be given early in disease. So from day 1 of symptom onset to about day 5 is really your best window. You can give it up till 10 days, but you really want to try to decrease that viral load early in the disease. So it's recommended for outpatient use, non-hospitalized patients, patients who have mild to moderate disease, but are at high risk for progressing to severe disease, and patients who are not requiring any oxygen, or at least not anything more than their baseline oxygen. One thing I wanted to point out was that vaccination, now that we have vaccine out, and that's a change from before, you want to delay vaccination by 3 months after receiving monoclonal antibody. The next drug is remdesivir, which again also hits at the viral response. And this is a nucleoside analog which inhibits the RNA-dependent RNA polymerase of coronaviruses. And this drug, was really the drug back in the first couple months, and everyone was trying to get their hands on it. And we did not receive the drug at least 2 months into the pandemic. And those institutions that had it, it was being used under emergency use authorization or compassionate use. And in October 22nd, it was FDA approved. The approval for remdesivir was really based on randomized control trial, which showed that hospitalized patients with COVID-19 who received remdesivir had a median recovery time of 11 days versus 15 days with placebo. Now, I want to point out what's important here is to realize that the greatest drug benefit was seen in patients who were not on high flow oxygen or non-invasive mechanical ventilation or on ECMO, but the greatest benefit was really in those patients requiring a few liters of oxygen. There are many institutions who actually don't give remdesivir to patients who are admitted and go straight to the ICU and are on high flow mechanical ventilation. The idea behind that is that they probably are really a lot later into their disease, so there may not be much benefit from giving remdesivir at that time. And so they're kind of over that viral response and they're getting into the more of the host inflammatory response. So, I talked about 2 drugs that address the viral response, but let's talk more about the host response. So corticosteroids, we've used them for years and seen a lot of benefit with COVID-19. Patients with severe COVID-19 disease are at risk for systemic inflammatory response, which can lead to multi-system organ failure. Recommendations for the use of corticosteroids is based on large randomized trial, the recovery trial, which showed the mortality for COVID-19 was lower among patients who were randomized to receive dexamethasone versus standard care. And this is interesting because corticosteroids is really contraindicated in other viral illnesses such as influenza, but we have seen benefit with it with COVID-19. And that takes me to tocilizumab, which is, this is kind of interesting. This is where we've seen kind of the most change from when the pandemic started to now. Tocilizumab is another anti-inflammatory agent, an IL-6 receptor antibody approved for certain rheumatologic diseases and cytokine release syndrome. Initial randomized clinical trials really did not show much benefit in tocilizumab when you look at primary and secondary endpoints. But more recent data has shown that hospitalized patients who receive tocilizumab, there's been a 44% less likely progression to mechanical ventilation or death compared to patients who receive placebo plus standard of care. So recently, the Infectious Disease Society guidelines has now been updated for tocilizumab, and they recommend among hospitalized patients with progressive, severe, or critical COVID-19 disease who have elevated biomarker or elevated markers of systemic inflammation, the panel does suggest the use of tocilizumab in addition to standard of care, which would be steroids. This is a nice chart that you can pull up also in the NIH treatment guidelines, and it really looks at combining that drug that hits the viral response with the drug that hits the host response. And if you look here, the first two areas here is talking about non-hospitalized and hospitalized patients, but both of these patients do not require oxygen or are not hypoxic. In those two categories, we don't recommend or the NIH, the guidelines don't recommend dexamethasone or other corticosteroids. Although I know in the outpatient setting, a lot of patients have been prescribed steroids from their primary doctors who have COVID-19 but are not admitted to the hospital. Where they do recommend dexamethasone plus or minus remdesivir is hospitalized patients who require oxygen but do not require high flow or non-invasive ventilation or ECMO or mechanical ventilation. Patients who are receiving high flow or non-invasive ventilation, you could give dexamethasone or dexamethasone plus remdesivir. And then those that are on mechanical ventilation or ECMO, they recommend dexamethasone by itself. In our institution, we are actually, anyone who is admitted and a new diagnosis of COVID, they're really getting remdesivir and steroids just off the bat. And then, we kind of see what their trajectory is as the days go on. So this really looks at remdesivir with steroids. There are some other drugs that have been paired up with remdesivir, anti-inflammatory agents. The baricitinib, which is the JAK inhibitor, which is also an anti-rheumatoid drug, has been looked at with remdesivir with some good data. I just want to hit on ivermectin. We don't use this at our institution. I mean, I know it's been out there, a lot of mention about ivermectin, which is a drug used to treat parasitic infections. The studies have showed that ivermectin may reduce the growth and replication of SARS-CoV-2 in the laboratory setting, in the in vitro setting, but at very high doses. But there could be a potential for antiviral and anti-inflammatory response, but we need more data. So at this time, we don't have enough evidence to recommend either for or against the use of ivermectin. And my last slide, I just wanted to, again, just give you another graph of looking at the different sort of categories of illness. We can have asymptomatic or pre-symptomatic infection, mild illness, moderate, severe, or critical. One patient who starts with mild can really stay mild and just recover, but then there's some that can go on to moderate, severe, and critical and still recover. So it's really hard to predict what the course is going to be like. We see the highest amount of viral replication in those early stages, and then we see more of the inflammation in the late stages. We want to use antiviral antibody therapy in the beginning stages and use anti-inflammatory such as tocilizumab, dexamethasone in the later stages of the disease. Our goal as practitioners, as healthcare, all the healthcare officials, our public health advisors, we try to be outside of this whole box, and this is where we want to be. We want to really use the preventive measures to avoid getting to any of these categories. So wearing our masks, washing our hands with soap and water, and maintaining that 6 feet of distance from one another. And then most recently, this is one of our biggest preventive measures is vaccination. And with that, I think this is a good transition to Dr. File's slides. Thank you.
Thank you, Dr. Agrawal.
Okay. Well, thank you very much, Shanu, and thank you for inviting me to participate in this webinar as well. And Shanu, if you'd be so kind, you could control my slides as well, since I think you have them on your shared screen there. So if you can go to my first slide, which is just, I think, an introductory slide anyway.
Let's see here.
Let me just say while you're starting, I mean, I want to echo what Shanu said about, the first case in the United States being admitted to the hospital actually in the state of Washington on January 20th. I mean, to me personally, anecdotally, that was very interesting because I received an email the next day on the 22nd of January from one of our colleagues from the Infectious Diseases Society of America, who indeed just admitted that patient. So he was notifying me about this. And at that time, I would have never anticipated that here it is a year later, we have over 28 million Americans infected, over 500,000 have died from this. I mean, it's just obviously an unprecedented pandemic that has been something that has affected all of us. So let me just go to the next slide. And basically what I'm going to do is just go over very quickly some of my selected thoughts about what we've learned over the last year. Now, like the endemic coronaviruses that we've known about for the last 50 or 60 years, which are associated with sort of mild cold-like illness, this virus, this new coronavirus, novel coronavirus, probably evolved, well, I'm sure it did evolve from animals and specifically bats, and it may have gone through a secondary mammal that then allowed it to infect humans. But it's very similar to the other novel viruses, the other two we've seen in the last 20 years. I mean, severe acute respiratory illness that was primarily in China, but did go to other parts of the world as well. But however, that was much different because literally within about 3 months, that particular epidemic, maybe a little bit of a pandemic, was actually terminated. And it was terminated because unlike the SARS-CoV-2, there was virtually no asymptomatic spread. So if you had patients who were sick and you quarantine them, you could stop transmission. The other part about the virology I'll mention subsequently is about the concern that we have for the variants. But I just mentioned transmission and why this particular virus is so unique and so difficult to contain, because as many as 40 to 50% of the patients who are infected really don't have illness with it or disease with it, but yet they can spread it. And so that's why it's so difficult to contain it. And that's why it's so important to have mitigation practices so that we all wear masks and distance so that we try to reduce that spread if we are infected, but yet asymptomatic. Now, Shanu briefly mentioned something about the symptoms. If you remember last spring and maybe to the early summer, I mean, we were primarily focusing on more severe infections, and particularly those patients who had pneumonia. And we only talked about 3 symptoms of fever, shortness of breath, cough. But then now we know that virtually any symptom, I mean, even involving the not only the respiratory symptom, but also GI symptom, et cetera, cutaneous symptom, rashes, whatever can be associated with this. And obviously a big one is loss of smell and then subsequently taste. Shinu already went over, we now know much more about the pathophysiology, which impacts how we therapeutically manage these patients. And of course, the big concern now is these long-term effects. If you look at the literature, there's really not a consensus definition about how to define these. I mean, some of them call post-acute COVID within about 3 to 12 weeks post resolution of infection. And then after 12 weeks, if you still have symptoms, then the so-called long-term COVID. But this is something that I think we need much more information and follow up on. But as Shanu mentioned, obviously now the big issue, and I think how we're going to get out of this pandemic is the vaccine. So the next slide, I have some information about the vaccines. I've got 5 of them listed here, but I'm only going to focus on those that with the asterisk on top, because those are the ones now that have received FDA designated EUA, and those are the ones that were actively vaccinated in this country. They all target the spike protein. As we all know, that's the part of the virus that attaches to the ACE2 receptors that allows the virus to therefore infect cells. So that is the target of all of these vaccines for which antibodies are developed. The technology is a little bit different, as we're aware. The Moderna and the Pfizer is the messenger RNA technology, which is relatively new to mass vaccination, but it's actually been in development for over approximately a decade, whereas the J&J is a vector vaccine where the genetic code for the spike protein is inserted into a adenovirus 26, which has been altered so that it cannot replicate, and that's inserted into the patient. Then it presents the genetic code for the spike protein to our immune system. We develop antibodies to it, et cetera, et cetera. As far as refrigeration, we know that the Pfizer initially required ultra code, but now that's been revised to just freezer, whereas the J&J is just regular refrigeration. What about the efficacy? And this is truly amazing, to have a vaccine that prevents the endpoint, which at least for Moderna and Pfizer and J&J is clinical infection or symptomatic infection. So the Moderna and Pfizer, 94%, 95%. For J&J, it's 66%. But you really can't compare those vaccine efficacy rates because J&J study was done later. It was done in more geographic areas, including South Africa, where we probably have our most potentially vaccine resistant variant. But even in South Africa, it was effective against where virtually 95% of all the strains were this variant. 57% of the recipients who did receive the vaccine did not have any disease. But even more importantly, it was able to prevent serious disease, patients coming into the hospital and death, even in South Africa. So if you look at the efficacy against severe disease, very effective. I mean, you could say it's 100% when you look at the clinical trials. And then the other issue is, what's the efficacy? What data do we have of these vaccines preventing asymptomatic infection, which is very important, which means, does it truly prevent infection? And then as a correlate, therefore, does it prevent transmission? This is going to be extremely important when we talk about herd immunity. And the very preliminary data suggests that it does. I mean, with the Moderna, that study did look at swabs looking for PCRs before the second dose was given. And there was a reduction just before the second dose of 72% of those patients who had asymptomatic infection. Similarly, in the J&J study, there was seroconversion studies. So that patients, even if they didn't have disease or weren't sick, antibodies directed against the non-spike protein. Obviously, they're going to have antibodies to the spike protein, but you can detect antibodies against the nucleic capsid, detect antibodies against other parts of the virus that would not necessarily be stimulated because of the vaccine. And again, there was a reduction of over 70% of the patients who had these positive antibodies were in the placebo arm, not the active vaccine arm. So there is a suggestion that these vaccines will prevent infection and therefore transmission as well, which is very important. Next slide. Now, as we all know, these vaccines are somewhat reactogenic. I mean, they're somewhat more associated with side effects, but they're to be expected. And so when we counsel patients, we say, look, don't be concerned if you have these symptoms of pain at injection site, low-grade fever, arthralgias, headache, myalgias. This is part of your immune system acting, and it's going to be transient. There are a few differences here that I'm showing from the studies, in that the local lymphadenopathy or axillary swelling is more associated with the Moderna, whereas diarrhea is more associated with the Pfizer, and arthralgia more with the Moderna and the Pfizer as well, and less with the Janssen. If you look at the pain at injection site, it seemed to be somewhat less with the Janssen. It was about 50% with Janssen and about 80% with Moderna and Pfizer. But other than that, they're all fairly similar from the standpoint of low-grade fever, arthralgias, headache, and myalgias. Next slide.
Turn right after 600 feet.
Well, that's interesting. Well, maybe that's how far we have to distance. But at any rate, let me talk a little bit about the variants, because that's the greatest concern now. And let me just point out that all RNA viruses, particularly respiratory viruses, they commonly mutate. They're going to mutate, they're going to change, they're going to have these random mutations as they replicate, so that the greater the transmission rate, the greater the chance for mutations. That's why it's really important for us, until we get herd immunity, whatever that's going to be, that we still practice a mitigation behavior to try to reduce transmission within the communities, therefore reduce the development of these variants. As I said, there's always going to be mutations that are occurring as these viruses replicate. For the most part, 99.99% of these variants or mutants probably have no clinical relevance at all, but some of them may afford an advantage to the virus. And most of them, as I'll show in just a second, have some degree of increased transmissibility. And that's because they have a greater affinity for these ACE2 receptors. So more of them can infect the cells. And that also leads to a higher viral load, which means there's probably more shedding of the virus that can allow transmission. There's also a concern, but it's not well established, that there may be a longer duration of shedding. We're not particularly sure. And it's possibly there may be more environmental stability in the environment, that is on inanimate objects. But again, that's not totally clear. So what's the clinical impact of these variants? Well, as far as the impact on antiviral remdesivir, there's no impact there, because the remdesivir doesn't work at the spike protein area. It's a nucleotide analog, as Shanu already mentioned, and affects polymerase reaction. So it's not going to be of concern with the variants. However, the monoclonal antibodies, particularly the single monoclonal antibodies, as opposed to the dual monoclonal antibodies, there definitely has been shown to be reduced efficacy. So that's why primarily we're only using the dual monoclonal antibodies. And then lastly, the real concern, the $64,000 question, is what is going to be the effect on the benefit of the vaccines. And so if we can go to the next slide, I want to end with this. And I want to point out, and I'm showing, well, how many of the variants here? 1, 2, 3, 4, 6. But first of all, I want to sort of point out that the predominant strain we're seeing in this country, and which we've seen in this country almost for the last 10 or 11 months, has been a variant. And that's this so-called D614G. This is different than this initial Wuhan virus that initially was the start of the pandemic. However, this particular variant really had no significant clinical significance at all. It may have been somewhat higher in transmissibility, but it certainly had no impact on severity of illness and mortality. And there was no issue of resistance to the vaccine. The most common of these variants, the one that was started, or at least initially identified in the United Kingdom, is the B117 variant. Now it's represents about somewhere between 10 and 15%, maybe 20% of the strains in this country. It's actually gone from about 2 or 5% 2 weeks ago to about 10 to 15%. And it's thought by the end of this month that may be the predominant strain. This is associated with a higher number of spike changes, definitely higher transmission rate, and there does appear to be increased severity. Mortality can be 30% greater. The risk of reinfection after the wild type, or let's say the D614 strain or G strain, which is a predominant strain now in the world, is little. And there appears to be very little vaccine resistance. I mean, if you look at the effect of this variant, as far as neutralizing antibodies, it may reduce neutralizing antibodies by 1 or 2-fold, or maybe 3-fold. But quite honestly, in all of 3 of the vaccines that are available in this country, we get such high antibody titers that a drop of 1 or 2-fold is not going to have a clinical impact. Now, if we go, however, to the next variant, that's the one that we're concerned about, is possibly having a significant reduction in the efficacy of the vaccine. But I already told you that this particular strain was included in the study of the J&J vaccine, and still it's significantly, that vaccine anyway, in South Africa, significantly reduced serious disease. It reduced significantly by 80 to 90% of patients sick enough to come in the hospital. And if you look at after 28 days of the J&J strain, it prevented death, although the deaths were like 7 versus 0, but it was very effective there. Now, the next one is this Brazil strain. We have less information about this, the P1 Brazil strain, but it does appear that certainly this is associated with higher transmission. It may be associated with increased mortality. We really don't know to what extent it's going to have an effect on the vaccine. But fortunately, right now, there's very limited numbers of cases in the United States. I mean, as of earlier this week, at least on Monday, there were only 10 isolates of this identified in the United States. And then you may be aware that there's other strains in California and New York. Actually, New York, there's several hundred, probably thousands of strains to this New York strain. We really don't know the information associated with transmission, mortality, or risk of infection or vaccine resistance there. But my take on this is that the vaccine, as long as we can get this uptake into a high percentage of the population, is going to significantly reduce these developments of these vaccine or the variants, because we're going to reduce transmission. But it's also another reason why we still have to maintain good compliance with mitigation practices, so also to reduce transmission. And so if we do both of those until we get good herd immunity, which I'm hoping can occur within 2 to 3 or 4 months at the most, then we can start reducing some of these restrictions and opening up the economy to a greater extent. So I think I'll conclude there, and thank you again for your interest, intention.
Thank you, Dr. Fowler and Dr. Agrawal. It was very excellent presentation. We learned a lot about COVID-19 management and vaccine update. So we are going to take the question at the end, and we'll move on to the next presentation, which is going to be by Dr. Reina. Dr. Reina is a nephrologist, adult pediatric nephrologist practicing at Akron Children's Hospital, Akron General, and Suma Health. So let's welcome Dr. Reina.
I hope everybody can see my screen, or?
Yes, we can, yeah.
Okay. Well, good evening, everybody. First of all, I want to thank Dr. File, Dr. Agarwal, and Dr. Chandler to be one of the panel discussant of COVID-19, almost going to be a year. It's a pretty tough year for all of us, and welcome them and giving this nice lectures to the EPNO. And we are very proud that this is live and up and running and being shared by API, which is the All Indian Association of the Indian origin physicians all over the country, and it's been live streamed in some of the medical schools and also being live streamed to the residency program. I'll go very quickly, and this all started, and it's a nice transition actually after Dr. File, and then it's followed by Dr. Chandler. And I just want to kind of set up the stage for the nephrology standpoint of view. When this COVID was growing as a system which is more or less been affected by the chemokine burst, this dysregulation of the immune response and infection to COVID-19 was evolving. And we have learned a lot from the experience from China and then evolving into Europe. And it's finally end to the main cause of this dysregulation of the immune response was mainly due to dysregulation of the innate immune response. And what we have identified in the nephrology world is that the SARC virus has been associated with a strong activation of the IL-1 and IL-6 pathway, which is always a controversy for us in the sepsis world, and Dr. Chandler can add to it, that whether we should be removing these chemokine bursts, which happens in the setting of the sepsis and multi-organ failure at the initial stage. And these chemokine bursts can cause a multi-system organ failure. And it's found out, we did like 2 or 3 studies. One is coming in blood purification. We did a systemic review, and we found out the incidence of the AKI in COVID-19 is around 27%. And the people who are needing any kind of renal replacement therapy, the mortality rate is increased to 60 to 67%. And various thought process, various pathogenesis factors have been involved with the COVID-19. Some of the evidence have shown that it has a direct viral effect in the form of endothelial damage on the podocytes. The virus has been identified. There's some collapsing FSGS in APL1 gene co-expressed together, but also it has been proposed mechanism is mainly the chemokine burst, which occurs as the virus enter and replicate and causes a profound increase in IL-1 and IL-6. Then the ASN and Pediatric Critical Care Society and the International Pediatric Nephrology Association, which I led the PCRRT and IPNA, we came up to the proposal with this COVID-19, maybe we need an extracorporeal blood purification system, because it has been shown, it has been proven before that this could be removed through the adsorption mechanism with various modality of the extracorporeal blood purification system that may help in removing the inflammatory cytokines, damaged associated molecular pattern, which is DAMS, which is very much proven to cause the direct effect on the various organ, and maybe that endotoxin and SARC virus are possible contributors to the multi-system organ failure may be improved because we can remove or we can mitigate in the chemokine removal through this blood purification system. This is a paper that came out in pediatric nephrology. And as you can see how the SARC virus comes in and affect the replicate and basically present in three forms. It can go into the lung and causes direct injury, which is ARDS. It can go and cause a profound increase of the chemokine burst. It causes endothelial damage, podocyte localization, proximal tubule localization. So then there was a thought process, and then FDA approved these cytoabsorption mechanism where we said maybe we can interrupt or we can stop this cytokine storm using the HA380 or HA330 disposable hemoperfusion cartridge, Cytosorb Oxeris, or we can start with a high flow CRRT, which can be initiated with the fluid overload, septic shock, and maybe we can use the high flow CRRT, which is the total effluent dose of around 50 ml per kilogram per hour, and that can provide more convective and diffusive clearance, mainly convective, removing the bigger molecules. Then immunomodulation was thought to be a potential adjunctive management strategy for patients with severe COVID-19. And I remember when this was first approved, special thanks to Dr. Chandler. And we had, within a month of the FDA approval, we got this Oxeris filter to be up and running in our ICU in Suma. So far, we have done 9 patients with the Oxeris filter. And this is just to show you the removal of the circulating immunomodulator mediators that may prevent or mitigate the organ failures in patients with COVID-19. And we have used in Suma the Oxeris filters, which is actually can be used in a regular CRRT Prisma machine. And instead of using our regular M150 or HF 1400 or HF 1000, we use the Oxeris filter. And it has been shown that it in vitro and vivo both, that it shows significant IL-6 reduction and our associated improvement in our SOFA score in multi-organ dysfunction syndrome, and particularly short-term endpoints such as hemodynamically stability and oxidation index. And when we were writing the protocol with Dr. Chandler and Shanu, actually Dr. Agarwal, in the Suma, we decided that we will do this Oxeris filter for 12 to 24 hours, maximum to 48 hours, because we don't want to remove the good chemokines that come into play after 48 hours. And our indications for instituting this Oxeris filter in our hospital system was fluid overload, respiratory failures, patient on ECMO, or having a multi-organ dysfunction failure. And we have done around 9 cases and we have a good response, but again, it's an adjunct treatment. And when FDA approved, it was a postulate that maybe the IL-6 contributing to this can be removed or mitigated by this filter. There are 2 filters, one is Cytosorb and Oxeris, and Oxeris has been approved mainly in Suma, and we are using it as an AM69 copolymer covered with polyethylene and unfractionated heparin, and it has a capability of absorbing the endotoxin and cytokine. And we have, together with our own ICU group, has published around 2 cases. One is systemic review, and I'm writing our case series with Dr. Velko and other ICU attending with our experience. And it is actually amazing that we have used in SUMA the Auxeris filter. We are just priming it with fibrin. We are priming it with heparin so that we do not develop a lot of fibrins, because these are all very strong chemokine that absorb. And we have not used any extracorporeal anticoagulation, and we have combined the high flow CRRT with the effluent dose of 50 ml per kilogram per hour using Auxeris filter. And we have good response rate, at least with the hemodynamic stability, fluid removal of all the endotoxin, and maybe helping AKI and decreasing the ventilation time. And this is our protocol for Auxeris in using CKRT. Now we call it the continuous kidney instead of continuous renal replacement therapy that we just approved from our KDIGO guideline 3 months ago. So this is just a nice setup to see how we moved in SUMA so fast within an FDA approval. And thanks to Shanu and Dr. Chandler. And remember, initially there was a lot of hurdles to put this in place, putting into protocol. And I'm happy to share that we have this available, and we have used around, at least I personally use it in 9 patients, and we have a good response with that. And with that kind of a introduction, I will hand over to Dr. Chandler. Dr. Chandler is our chief of our critical care medicine in the SUMA. And Dr. Chandler has been, I will say, my mentor in bringing this novel therapy to our CRRT group in the SUMA. And because of this effort, we can up and run the Auxeris filter within 30 days of FDA approval. With that, I will defer it to Dr. Chandler, who's the chief of our critical care SUMA Health.
Well, thank you, Dr. Reyna, and thank you everybody for inviting me this. Honestly, it's been, one very shining point of this whole experience has been the collaborative nature of physician and provider care, both institutionally and between institutionally to deal with the COVID pandemic. Let me jump into my talk. Rupesh, it's saying I can't share the screen while someone else is sharing.
Dr. Mehta, can you look at it? Because
yeah, she should be shared now. Yeah, thank you.
Thank you.
I'm terrible about sharing. It's been a problem since childhood. All right, so again, thank you for inviting me. I'll be providing a critical care perspective, and then also talking about some of the pulmonary complications of this for COVID survivors. And just, I think one thing that may come across is the importance of what Dr. File was saying with the vaccine protecting us with even the variants of disease. It may not prevent infection, but by decreasing the severity of the disease, that is quite critical. So if for the first part, I just would like your indulgence, because, I think it's important to recognize the challenges that we've overcome, because the second part of the talk is talking about some of these issues in the ICU and for our COVID survivors, which clearly are not sorted. So just for folks' recollection, I think in March this time, or a little later this month, a year ago, the situation was quite dire in New York City. 3 New Yorkers were dying every 3 minutes. Emergency field hospitals were being erected. Naval vessels were being shipped in to provide care for non-COVID patients. And in terms of, lowering the curve, the medical system at New York City, and New York in general, were several thousand bed shorts from what they needed. It was a bad time for the US. Issues that were occurring and that we were hearing here in Ohio were situations where, due to ventilator shortages, 2 patients were being placed on a single ventilator. And by the end of March, there were non-intensivists and non-anesthesiologists managing vents long-term for several days. So these were ER physicians and primary care physicians. And then in the New England Journal of Medicine published a similar, not quite as grim, though concerning, series of case reports from the West Coast, from Seattle, where, you know, at the time of this publication, only 20% of the patients had survived to discharge, 50% had died. In the diagram you see before you, red is ventilator, and the majority of the ventilated patients had died, and the rest had remained hospitalized. We are here in Fortress, Ohio, getting this information, obviously concerned about the direction things are going. So to address this, you know, Dr. Mike DeWine declared a state of emergency. And here at SUMA and other regional hospitals, we were collaborating, you name it, UH, Cleveland Clinic, Ohio State, meeting on regional levels to try to address a response, and honestly co-participating in surge preparation. In fact, playing, you know, a very open handbook on how were we going to place 2 patients on a single ventilator in the event of ventilator shortages, which the image to the right is an example of, a sim lab. We were sharing sim lab data with our other hospitals on how to make this a actionable strategy. And the Society of Critical Care Medicine was trying to come up with ideas so that a single ICU doctor could take care of 50 to 100 critically ill patients in the event of that. So they published a tiered staffing strategy, which we actually dry runned at SUMA for a week, where my brother, also an intensivist, was able to manage 50 critically ill patients by using several teams of non-intensivists in a tiered structure. And we had data from that that showed that the outcomes were excellent for all those patients. Mercifully, you know, by May 7th, you know, we had made sufficient preparations that in North America, this is a study published in CHEST, but most intensivists felt that we had sufficient ICU beds and sufficient material to deal with whatever surge that we were anticipating seeing. You can see globally that other intensivists were not feeling the same way. And there were certainly some desperate situations going on elsewhere in lesser developed countries. And thusly in Ohio, we were reopening. May 21st, we reopened to indoor dining, and we're having indoor commercial experiences, and things were looking pretty good for Ohio. And then we were hit with a post-Thanksgiving surge. So you can see this from the Ohio Department of Health, where it had been all quiet on the Western Front. And then, you know, a few weeks after Thanksgiving, due to, you know, a sort of commingling and a loosening of you know, mitigation strategies, much like Dr. File is cautioning against, that may be occurring in states right now, we saw a large increase in the number of COVID cases. This is an example of the cases per 100,000 patients. And this is a diagram showing how full the ICUs were when this hit. Here at SUMA, we doubled our ICU services. So we were literally taking care of twice as many ICU patients as we typically were during this period. And we're only able to do so because of some of our preparations that had taken place previously. As of yesterday, the Ohio Health Advisory published their data, which is reassuring. Like, so you guys, I don't know, are familiar with this, but basically there's 7 indicators that inform or declare our risk of emergency here in Ohio based off your county. And Summit County, where SUMA is in, has seen a decrease in their new cases, a sort of a gentle decrease in their ED visits, certainly a sharp decrease in outpatient visits, and certainly a sharp decrease in their hospital admissions. And our ICUs both have breathing room in terms of the percentage of their patients who have COVID and the percentage of their hospital beds that remain open. So it looks better. But I was asked to talk about some of what we're seeing in terms of the diseases both in the ICU and then when they leave the ICU. And so when you are graduating to requiring intensive care, the vast majority of those patients will have ARDS, or acute respiratory distress syndrome, from COVID-19 pneumonia, which I think we all are now familiar with, will show a sort of ground glass appearance on both chest X-ray or CAT scan. And the image on the left is from the original JAMA article out of Wuhan, which in the top series of images shows a diffuse ground glass appearance affecting all lung lobes from the apices to the basis. And the second CT on the bottom is showing a follow-up CT in the same patient 19 days after symptom onset, which is still rather significant disease, and then has new areas of, air trapping or dropout. For instance, here, where there's been some lung injury and some permanent injury to the lungs. A concerning CT to see that much permanent damage 19 days into the illness, and also a concerning CT to see that much active inflammation 19 days into the illness. We've now had a number of studies published, and most recently, just this month in Chest, show that the vast majority of these patients are having a diffuse alveolar damage type pathophysiology on their histopathology, and that 50% will go on to develop organizing fibrosis. So sort of a common, it's following the ARDS pathway. I will say, to comment on it, we are seeing more microthrombotic complications in these pathology biopsies than we are used to seeing in standard ARDS, which is a clear distinction. We saw a high amount of microthromboses with SARS, but not, for instance, with H1N1 or other non-SARS causes of ARDS. So just to be aware, there are some differences. In terms of improving outcomes in the ICU, I have some more slides here to come, but at this point it is clear we were seeing wide variations in how rigid or stiff the lungs were to ventilate, which was causing, unfortunately, a wide variation of practice because we weren't seeing the same phenotype. At the end of the day, though, it looks like protocolized care and trying to treat, ARDS using standard ARDS strategies is the best strategy. And it's certainly borne out in biopsy results that these patients do indeed have diffuse alveolar damage consistent with normal ARDS. And so what this means is that, you try to use non-invasive ventilation to spare mechanical ventilation because the risks of mortality are high. We'll talk about that in a second. And like we do for standard ARDS, we're definitely encouraging low tidal volumes. We want to decrease, or be very conservative with fluid management because too much fluids will cause worsened third spacing and worsened non-cardiogenic pulmonary edema. And you want to prone these patients early, just like you would for non-COVID ARDS patients. And if you can bundle all these in protocolized care, you can decrease your overall mortality for ICU COVID patients from 56% to 37%. These are high mortalities in the ICU that I'm describing here, much higher than the standard mortality for normal ICU patients. Thromboembolic disease has become a real issue, both inpatient and outpatient. I talked to my vascular surgery colleagues, and they're getting inundated with referrals for patients who are presenting with both acute DVTs and acute arterial thromboses. And we're certainly seeing the same thing on the inpatient side, where we'll see patients develop distal DVTs despite standard doses of thromboprophylaxis. And then we'll see propagation of those distal DVTs despite appropriate thromboprophylaxis and sometimes despite full anticoagulation. So thrombotic complications are a real problem, both inpatient and outpatient. In the ICU, we know that empiric anticoagulation, which we were trying, was a bad idea now. And what you see below is the Kaplan-Meier curve for survival, whether you use prophylactic or therapeutic anticoagulation. So empiric therapeutic versus prophylactic in the ICU. And you can see that they're overlapping. There does not appear to be an advantage to empiric anticoagulation and was a disadvantage with some issues with recurrent bleeding. I can tell you early returns, it looks like for patients who have COVID, we may be doing empiric anticoagulation for non-critical care patients, so general medical patients. There's a study we're seeing some early data from that may indicate that those patients may benefit from being placed on empiric full anticoagulation. But that currently is not a good idea in the ICU. We see a very high rate of secondary infections with COVID, which may be no surprise, with a positive BAL rate of up to 58%. And this is prompting us to do bronchoscopies more often than we typically would for ICU patients. As a bronchoscopist, it's a safe procedure for myself and for my patients. These are the slides that are discouraging. So these are far higher mortalities than I'm used to seeing for ventilated patients. And this is very up-to-date information published, honestly, just a couple of weeks ago. But you can see those mortality numbers are striking. I have another slide, but you know, the benefit for avoiding severe disease and trying to prevent ventilator requirement is immense. And you really do want to avoid your patients being in these situations. Those numbers, particularly for the 60 to 70 age group of 71% mortality if they require the ventilator, are just absurdly high. But honestly, in keeping with what myself and my colleagues at other institutions are seeing for that age group. And this is from the Discovery Registry, which is supported by the Society of Critical Care Medicine. And this is another way of looking at the mortality issues and the morbidity issues for patients who have COVID as they have increasing organ dysfunction. And so you can see their all-comer data in this registry, mostly of US patients, but elsewhere as well. Shows an overall mechanical ventilation mortality of 41%. And then as you add increasing organ dysfunction, increasing mortality. And then the length of stays are striking, and the discharge home numbers are also striking. And I will tell you again, because patients, you know, aren't being discharged home, we don't know, you know, a significant chunk of those patients will ultimately end up dying. So these are concerning times in the ICU, and it's a very tough place to work right now. What about when you survived your harrowing hospital stay? What about this post-COVID syndrome? And it's a syndrome, and I'm going to focus more on the pulmonary aspects of this, but it is a syndrome with multiple organ dysfunctions, and it requires a systematic approach to handling these patients. And but I'll focus on just the pulmonary standpoint. So there is now some, again, from just this past month, some interesting studies that are following up, doing systematic high-res CTs on COVID patients. And so this one was on 3 months, so a before and after study on patients who survived their intubation who had COVID. Not surprisingly, 91% of these patients have fibrosis. So that's just areas of honeycombing and sort of circling around on that top series. And then at 3 months, they're still having some fibrosis, so some scarring. You can see these blebs where they now have new emphysematous changes, and these are in non-smokers. And then here's another area of scarring in this bottom series. But then also concerningly is areas of still some subtle subpleural ground glass inflammation. So there's ground glass opacities or ongoing inflammation up to 3 months in 89% of these patients who had COVID and were intubated. So that bucket of patients is the more severely ill, but that's concerning that there's still ongoing inflammation. More concerning are these data from Lancet published this month that are following up a large Wuhan population that if you were admitted and required oxygen at 6 months, got PFTs, a third of those patients had abnormal diffusing capacity on their PFTs and an abnormal 6-minute walk test. And then God forbid that you required high flow nasal cannula or non-invasive, more than half of those patients are having diffusion issues, with a decent number of those requiring supplemental oxygen at rest because of that. And a third of those are having abnormal 6-minute walk tests. What we are now, because of the newness of this illness, is in the phase where we're still phenotyping this disease. I can tell you informally, there's various therapeutics that are being explored, and there are some clinical trials now being cobbled together, things that are being, I think more widely experimented with right now is the use of colchicine and various courses of prednisone in these patients. But again, these studies for me to sit down in a organized fashion and tell you what therapeutics are effective are lacking. And we are kind of where we were last March when we were dealing with acute COVID issues in terms of trying to deal with some of these post-COVID phenomena that we're seeing. The only advice I can give to you is this infogram from the British Medical Journal late last year, which is exploring and goes through sort of the supportive care for the multiple organ system dysfunctions that you can see for our COVID survivors. And SUMA, like other places, is developing what are called, COVID long hauler clinics or post-COVID syndrome clinics to help deal with this multifaceted problem. I thank you for letting me speak and appreciate your attention. Thank you.
Thank you, Dr. Chandler. Thanks a lot. So we have Dr. Mehta, are you around? Dr. Mehta?
Yes, yes,
Are you
Professor.
around? We have a lot of questions on the Facebook side and a lot of questions in both the direction and also on our live stream. So we can take some from Facebook and we can take some from our live stream. And Dr. Mehta, can you take it from our chat, from our committee people? So I have a question, one from our live stream for Dr. File and Dr. Agarwal. The question is that, do you think that the 2 doses of the vaccine that we get will suffice and we do not need any booster, or there is any potential other vaccine that needs to be developed for the new variant, which is being up in UK?
Well, I'll start with that, but the answer is we don't know, quite honestly. My hope is that if we can get enough people vaccinated fairly quickly, that we will get enough reduction in transmission that we won't need a additional vaccine to specifically address some of these variants. I thought you were going to ask, do we really need the second dose of these 2-dose vaccines like the Moderna and the Pfizer? The answer there, from my perspective, is definitely yes. I mean, there is some controversy there. Some people have been promoting, let's just delay the second one so we can get more people with that first one. But the principle of that 2-dose vaccine is that the first dose primes the immune system. It's really the second dose that you need to get high enough neutralizing antibodies that you effectively are able to neutralize these variants. And so with the onset of these variants, it's extremely critical we get that second dose in, and ideally according to the schedule of the 2 vaccines.
That exactly, there was another question I was about to put. There was like 7 people asking me this question. You already answers, which is good. Shanu, can I ask you a question? There is a question about, what is the maximum time interval between first and second dose that people can wait? Because generally they are saying that we should get it within 4 weeks. So if there is any issue, people want to prolong, what is a maximum time interval between first and second dose?
So, the CDC has recently, their recommendations, so between your first and second dose, so if you were to get Moderna, you should get your second dose at day 28, but for some reason, if it's not available, you can push it out to day 42 if you need to. So you could push it out 6 weeks. And for Pfizer vaccine, that would be, day 1, you get first dose, 21 days, you get the second dose, but you can push that out as well to day 42. Recent guidelines from CDC or recommendations, if there's some shortage or you're unable to get the same, the same company of second dose vaccine. So if you had Moderna, and if you cannot get Moderna, but you're able to get Pfizer, that's okay. And ideally, you would like to get the same dose, but you can get an mRNA vaccine. Also, then another that just came up, and actually Dr. File and I were just talking about this. We've had some instances where people had gotten their first dose, maybe because it was like a wasted dose for some reason, and there was no guarantee on getting the second dose. If you get the first dose of an mRNA vaccine, you can actually get if you get the J&J, you can get the J&J after that as your second and last dose. It would be a first dose of a different vaccine, but you wouldn't need any follow-up dosing.
Okay. Thank you, Shanu. So again, the question for both Shanu and for Dr. File. The question is, Dr. File, any comments on AstraZeneca vaccine and the decision of the South Africa government to stop its administration?
Yeah, I was starting actually to respond in the chat, but actually the AstraZeneca vaccine in essence does not engender as high neutralizing antibodies as the other 3 that we've discussed. And it's really strange, because I don't know if you've really followed the development of that vaccine, but because of some sort of unusual circumstances where when they were developing this vaccine, some of the initial doses, because it's a 2 vaccine as well, some of the initial doses were not given in the standard dose. It was only a half dose. And the patients that got the half dose actually had a better response. But if you look at what the protocol established, or at least recommended, the response of that AstraZeneca vaccine for particularly that South African variant was not good. It's certainly not as good as the J&J. And so that's why they decided not to continue that vaccine, mainly because of vaccine efficacy.
Thank you. I think this question is for Dr. Chandler. That's from our critical care group from the East Side. Dr. Chandler, they're asking about your experience for using ECMO with ARDS and the mortality rate associated. Did you see the infective viral load is coming down, or is it the variant of the genetic drift from the virus that people are seeing less? I will say the morbidity and mortality. But basically, they want to know your experience with the ECMO, and then they want to know why the equity is going down in 2 to 3 months.
I can definitely comment on the first part of the question. I may ask Tom or Shanu to help me with the second part. The ECMO has been literally life-saving. Like, we have a high rate of success with using ECMO for our COVID patients. I will tell you that the ECMO run, so the duration of ECMO requirements are longer, just like everything, right? Like, I think everyone can appreciate on their own personal experience, like these length of stays, whether you're on the medical floor or ICU, and certainly your ECMO requirement, these are long runs on ECMO, but we are successfully decannulating our ECMO patients the majority of the time. And honestly, you know, for many months, we're running a continuous capacity of our ECMO with great success. So definitely a modality that's been life-saving for this. Now, yeah, the second question in terms of, yeah, I may defer to Tom or Shanu if they have any ideas, like with, I'm not regarding the shift of the virus, or.
The equity has gone down. So they are saying, is there any genetic drift in the variant that, and I don't understand, this looks like a complicated question. There's any genetic drift in the virus that the equity and the mortality and morbidity is actually getting better for the last, which may not be true or which may be true.
Yeah, I think, Tom, I think this was, I mean, talking about like the seasons and how we've had maybe less in the summer, and is that?
I think that's what the question is.
Yeah, Tom, do you want to hit on that? I think we've had that question before with the summer months being, you know, the lower numbers.
Well, if the question is about the seasonality, I mean, all of these are respiratory seasonal viruses. And we know that, for example, these the RNA viruses, even like influenza, there's a couple of things. Number one, they do better in cooler and drier environments. So in the summer, it's hotter and more humid, right? Plus, in the winter, more people congregate together inside, and so there's going to be an easier way to transmit. If part of the question was why is the mortality going down, I think it's because of like what Mike and Shanu are doing with the therapeutics. I mean, we know much better how to treat patients. I mean, remember last March and April, everybody was getting a drug which in retrospect was probably more harmful than good, and that's hydroxychloroquine, right? So I think we just learn more how best to treat our patients, when to give these interventions, and how best to treat them and support them with ICU modalities.
Right. Thank you.
Just to add what Tom's saying there too, initially, just to recall, like when it came out, there were society guidelines that were having us alter our normal critical care practice. So because, you know, we were delaying placing tracheostomy tubes because there were uncertainties about the degree of contamination and whether tracheostomy tube insertion could be done safely. And so we were deviating from our standard practices because of the uncertainty with taking care of this population. And as we answered those questions, we've now are treating our COVID-19 patients much like we would our other patients, with one big difference too, is these, it requires personal and institutional endurance to ride a patient through the long ICU stay that is required to get them home. And that is clearly different than something we've seen before. To have this large of a population, have these long of ICU stays, and to be willing to like try to guide them through it and grind them through that hospital stay, that also took a while to realize that we could, if we hang in there, these folks, they can survive and we can get them back home.
Yeah, and I just wanted to add, one thing is to keep in mind is when we were treating these patients in the beginning, I know Dr. Chandler and myself would talk quite a bit because, I would see patients on the floors, he would be in the ICU, we would then, some of the patients would come to the ICU, and steroids, for example, in the beginning, we didn't know if steroids were good or bad, and we didn't have these randomized control trials, the results of it. So, I was giving a half a mega keg every 12 hours, and I would talk to Dr. Chandler and say, hey, Mike, I think we should do this. I've talked to some of my colleagues at Henry Ford, and this is what, and because Michigan was hit before we were. So I was talking to some of my colleagues I trained with. So we were doing a lot of things. And I think the key was to be very transparent with the patients and their families, that you're trying your best, you don't know. And surprisingly, all the patients and the families were wonderful. I mean, they knew, they were like, just do whatever you think is the best for me. So, and then later we got all the studies, the results of the studies were coming through saying, oh, steroids are beneficial, but clinically we were seeing that, even though there was nothing to say you use it or you don't use it.
And I have to add to that is like, I have to give a credit to Dr. Chandler too, and Shanu both, as far as the renal replacement is concerned, like within 2 to 3 weeks, we have a plan in place for high flow. And Dr. Chandler was very proactive to get the filters. And we were the first in actually the South area to get that and to put that in perspective. Now, because of the time constraint, there's so many questions, but I'll take two. One I cannot ignore because Dr. Tan is asking that question, so I have to take that. It's, can you ask the speaker to comment on double or triple face masking? That's fun question. I think that will go to Dr. Agrawal and Dr. File. And the second question is for Dr. Chandler, and I cannot ignore this question. This is from our RP group from New Jersey. They are asking, how are you dealing with the burnout in the ICU critical care? Because that is a major issue in other cities. With that, I'll not take many other questions, and then I'll defer it to Dr. Mehta to close. I'm so sorry, we are a little bit crossing over the time, but some of the questions I cannot say no. So these are the last two questions I'm gonna put, and then I will close.
Yeah, as far as face masking, I'll start with, and Dr. File, please chime in. The CDC at this point is still recommending a face covering that covers your nose and the size of your face nicely for the community, anything that can prevent you from, sort of transmitting those particles. In the inpatient clinical setting, it's always a patient care approved mask with patients. So that's kind of where we stand. There has been no guidance to my knowledge that has changed as far as double masking, triple masking, as long as you have a mask that's well fit and covers your mouth and your nose.
Yeah, I agree with that. Actually, when you think about the mask, there's two issues here. There's the filtration part, and then there's the fit part. So if you have an N95 and it's not fit very well, it's not going to be very good. And I think there's been too much emphasis on this double masking or whatever. Any good mask that's fitting well is going to protect you and protect others around you. So I think the more important issue is just wearing a well-fitted mask. Now, we do know that if you do double masking and it's well fit, then you're going to have more filtration, but you really don't need that when you're out in the community or you're in the public. The more important issue is just wearing a mask.
And I guess I can comment on the burnout and honestly in the hospital, right? Like this has been a tremendous burden for the healthcare system in general. And there is no good answers for that. Like this has been the highest rate of ICU nursing retirements and general inpatient nursing retirements, both at our institution and at neighboring hospitals here that we've ever seen. And obviously, maybe not obviously, this has been the most personally and professionally difficult part of my life ever. Like this has been just a tremendous stressor. what we have been doing are, in the beginning of this illness, there was a thought that we would need to out-rotation providers just to prevent their being infected in a setting where we weren't able to test for COVID. And what we're trying to do now is out-rotation doctors and other providers so that they can have a break and try to collect themselves. Obviously, you need a robust, institutionally supported, like psychology, pastoral care, counseling support system, which we have here and we've been pushing on our colleagues. And then you also need to have safe communal experiences. So the nurses now have a large checkout space that is socially spaced, where they can actually check out with each other like they normally would do, whereas before they were each in their cubbies sort of isolated. It needs to be done in a safe manner, but being around your people and being able to see each other and reminded that you're not alone is an important psychological need. And now that we're able to do that in a safe manner, it's been sort of a boon here on the medical floors and certainly in the ICU. But there's no easy questions to that. And you're asking someone who is still, trying to cope with what he's been through. But I am encouraged by the collaborative nature of how we met this problem, that we are making progress, that people do care. Like the folks on this talk want to know more about COVID, and they want to pass that information on and help others. And it's been this, camaraderie and that has been the most sustaining through this whole process.
Thank you, Dr. Chandler. With this, I have a lot of questions. I'm not going to take it. It's already 8:20. And thank you again, Dr. Fayal, Dr. Agarwal, and Dr. Chandler for giving your time to EPNO. And it was very learning process that in a year, I always say we learned and we have gone through the pandemic, but it's just a very sad experience. This is never I anticipated to learn medicine with such a tough experience. And also I want to thank our nursing staff. They are involved with patients and how they are in a forefront. With that, I will give the final word of thanks stage to Dr. Mehta. And with that, after this, we'll conclude our webinar.
Thank you, Dr. Reena. Yeah, I would like to thank all of you for joining Dr. Fayal, Dr. Agarwal, Dr. Chandler for your time. I know Dr. Chandler is even in a call right now and he's helping us out from the hospital. So yeah, it was a very nice update about COVID-19 management and vaccines. There was a lot of learning, and thank you everyone for bringing everything on one platform, which is not an easy thing, to get all the knowledge. So I'd like to thank you, all of you, for joining us tonight. And then I would like to share about one thing. We have upcoming event coming on March 27th about celebrating women leadership in EPNO. So keep looking for that. And then with that, I will wish you everyone good night and stay safe. Thank you.
Thank you. And have a good call, Dr. Chandler. Thank you for giving your time. Thank you. Bye-bye. Bye.
Very good. Excellent.
Nasa,
Nasa,